On this episode of the Ask Mike Reinold Show, we talk about working with tight shoulders after surgery.
The Ask Mike Reinold Show. Helping people feel better, move better, and perform better.
Before we get to the podcast, I wanted to make sure you knew about my free online course on the Introduction to Performance Therapy and Training. If you want to learn how to get started optimizing and enhancing performance, this is the course for you. Head to mikereinold.com/performance to sign up today. Welcome back, everybody, to the latest episode of the Ask Mike Reinold Show. We're at Champion PT and Performance up in Boston, answering your questions. Anything you want to talk about, PT, sports performance, career advice, business stuff, anything you want to talk about, head to mikereinold.com, click on that podcast link, and you can fill out a form to keep asking us these questions. So let's see, what do we got today? We got Lenny Macrina, Dewesh Podell, Dave Tilley, Kevin Coughlin here answering your questions. Lenny, this is Aaliyah's first time doing a question, but she's not new to the podcast. We've been introducing her.
She's not new
for a few weeks now. It's been a few weeks.
She's been around for numerous weeks. We've all kept the same clothes on for those few weeks too. This is amazing how we haven't changed our clothes at all.
But we really don't anyway, though. So I don't even know if that's point. Even a valid we may switch an Under Armour logo to a Nike logo every now and then, but it's pretty much the same. But who do we have for students today, Len?
We have Aaliyah Penner, who will be reading the question today, apparently. She is from Duke University with her classmate and roommate, but not roommate in Boston, Grace Suggs from Duke University. Very confusing, I know. We still don't know the whole story. Dean Bonneau from George Washington University, and also Sean Bean from University of Nevada at Las Vegas. Apparently the Rebels, not the Running Rebels.
So roommates, this explains a lot because again, I've never seen such competitive, banging heads all day in the clinic. Grace is just shaking her head. No, they're really two of the nicest people that we have had. There's no competitiveness. Do you guys want to clear this up? What's the beef between you two? I'm going to let you guys speak about this.
Hash it out.
You have no beef? Just want to put that out there.
We were so confused by that. It's actually kind of cool to have a friend and a classmate with you, though, especially when you guys travel. I mean, so many students that travel around the country over here. So it's, just somebody to, I don't know, the way each other think a little bit, right? You probably studied together a little bit. That's kind of helpful. So it's good to have you. I'm glad you guys are friendly too, because man, that would be an awkward 12 weeks, right? If you guys really hated each other's guts. But anyway, let's get back on task here. So Aaliyah, what do we have for a question today?
Okay, Hannah from Michigan wants to know, how do you deal with shoulder tightness that develops post-shoulder surgery? It seems to be a big complication when young, hypermobile people have a labral repair and have to follow a very restricted protocol and heal quickly, making them very tight.
All right, great question, Hannah. And, really similar to what we talked about a few weeks ago with Jason about the knee flexion. I didn't realize how similar those questions were. But in retrospect, they're quite similar. but thank you. I think this one's a little bit more specific though, and this might have been what we were thinking here. So what Hannah's saying here is, how do you deal with shoulder tightness post shoulder surgery? And I think the difference was, if you flash back a few episodes, so if you haven't yet, go back, listen to a few episodes, but we answered a question about somebody was immobilized a little bit too long, probably after knee surgery, and they got tight from that. I think this one's a little different, right? Because what we're doing here is we had a procedure that intentionally tightened the person up. And I think that was, where I think this question is a little different with Hannah's, right? You have somebody like a hypermobile person with a labral repair and they get tight because they have a restricted protocol after, what do we do? So I don't know. Let's see. Kev, you want to start with this one here? I think, there's some good sound strategy we can give to help with this kind of concept. But Kev, what have you noticed in your experience?
Yeah. So I'll shout out Mike Scaduto to start here.
Wow. Yeah. Is that a first?
R.I.P.
Wow. Shout out to Scaduto.
Is he on the podcast? No.
Yeah,
No.
he's on. He doesn't listen to the episodes after, so we can speak freely here. This is for,
Yeah, exactly.
Mike's on his
All right.
monthly golf trip right now, so he's unable to attend. But Kev, what sorry.
Yeah, no, that's okay. So there was someone that I saw one visit that Scaduto's been seeing who he evaluated, I believe probably a month ago now. This guy's a pitcher. He's younger, say like early 20s. But he had an anterior inferior capsule repair and bank heart repair. So kind of similar procedure where the goal is to tighten the capsule. So he came in 4 months after his surgery. He was doing PT elsewhere, but when he came in, he was super tight, especially in that external rotation at 90-degree position. And I believe he came in somewhere around 100 degrees of external rotation, somewhere around like 130 on his left side. He's right-handed.
Oh, wow.
So yeah, definitely. And this guy has aspirations of playing professional baseball. So
Can he
definitely
switch hands to be? Can he be a lefty?
going to be a lefty, yeah. So definitely a big deal, and it's been really cool to watch the process. I think Mike kind of explained it to me where he's breaking it up in phases of treatment. So the first 4 phases, you think 4 months out, you're really getting after some strengthening at this point, but he prioritized those first 4 weeks of therapy to restore range of motion. And the guy would come in for an hour, and it was really an hour of manual therapy, just really moving his shoulder any way that he could, and that approach has worked. So we kind of start with heating the shoulder. I think that just calms things down. It's a good way to start before you start your manual therapy, and then we'll kind of follow that up with a lot of passive range of motion, especially in the restricted position, because 4 months out now, we don't really have any range of motion restriction. So even some strategies like contract, relax, or hold, relax type stuff seems to work for this guy. So it got to the point where at the end of the session, he'd be leaving with about 120, 125 degrees of motion. And then Mike gave him some things to work on at home. So very frequent motion throughout the day. I think it was like 10 or 20 reps of external rotation at that 90-degree abduction position where he could do it on his own with a golf club or a stick. And he just did that as frequently as possible. And at first there was a little rough spot where he was coming in back at like 110, but now they've been working together about a month, and that 4-week motion phase seems to have really helped. And he's coming in at like 120, 125, and he's leaving at like 130, 135. So they've made great progress. And I think the big takeaways are working on the motion a lot in the clinic and giving them something to work on at home. Because that frequent motion at home is really what's going to make the difference.
Yeah, I like that. And again, very similar to what we talked about with the knee a few weeks ago here too, is the frequency of what we do is super important. The part of what I like about what you said there, Kevin, here too, is that, every patient's a little different, right? So if you're just following a protocol, or maybe you're erring on the side of, conservative, for example, I think that approach is appropriate for several, types of people. But for this specific person, they have a functional and really like a work, right? Like need to get back to that end range of motion for them. So you could argue like, what's our end game with each patient kind of in front of you? And you say like, what's our ultimate goal? What's our end game with some of these things? For this person is, if they can't get their external rotation back, they're going to have a hard time being able to use their shoulder. So the end game of them being tight into external rotation is technically unacceptable to their goal in their functional like outcome that they're looking for. So that's one thing we have to keep in mind as we kind of bring them through this procedure. We also have to keep in mind that sometimes people get tight because they're mobilized, and sometimes they get tight because the surgery over tightens them a little bit, and that changes things a little bit from that approach too. So good stuff with this, specific person. They may have been a little bit over tight. They might have went a little bit slow. But for me, I think it's important as they're going through this process that we're checking their range of motion right? And I'd rather say, week 4, 5, 6, 7, 8, like, okay, your motion's there. Now let's back off, right? Let's check your motion. Okay, it's there. Now back off. If it's a touch behind, you're going to get behind and you're going to get more and more behind as it goes on. So it's kind of a sequence as we go on. But who else wants to add to that? I know, Len, you probably dealt with a ton of these surgical things. What are some of your strategies?
Yeah, I mean, I don't remember. Maybe the students or somebody can refresh my memory. How far out of surgery is this person? Do we know? I know it's a hypermobile person, meaning they have a lot of mobility.
This one wasn't specific, but
it was. I didn't think so. Okay,
sounds like Hannah sees this a lot.
To me, if somebody's hypermobile, I mean they have a lot of mobility, like Scaduto's patient who has 130 degrees of external rotation on their non-throwing side, I almost want them to get stiff. And I don't freak out because they're over time, even if it's a prolonged time than what you are comfortable with as a clinician, they loosen up. So I know we always try to hit our milestones of like 6 weeks out of surgery, 8 weeks out of surgery, they have full motion. But if somebody is hypermobile and they have a surgery to either tighten them or they just have a general surgery and they are tight and it's still 8 weeks out, I don't freak out. I'm actually happy because that means that they are going to maintain that mobility or that stability long-term, because that hypermobile person has too much elastin to collagen ratio in their tissue. So if you took sample biopsies of that person's shoulder or skin tissue or tissue in general, they have more elastin to collagen ratio than maybe me, who's not as hypermobile. And so I think that person is going to easily stretch out. There was a study, it was probably 15 to 20 years ago at this point, and I forget the author's name. It's a common surgeon who looked at biopsies of tissue in hypermobile patients, and they had a ton more elastin to collagen. And so to me, that tells me that elastin component is going to allow for the tissue to stretch out. So I want them to kind of get a little stiff. And then I'll use the principles that Kevin talked about of multiple bouts of motion a day to begin to assess their mobility and their end feel. If they have a really firm and like tight end feel or spasm end feel, I got to kind of modify stuff. But if it's kind of becoming capsular and stretchy, then I know that the tissue's ready to stretch out and then you can get the motion back. So again, don't freak out if they're hypermobile. That's probably a good thing because again, think of this person a year, 2 years, 3 years from now. Are they going to get too stretched out and all the limitations are now gone and now they're loose again? We want them to get that stability from the surgery and from some scarring too, believe it or not.
Yeah, I mean, I can't tell you how many people I've thought were too tight that somehow just magically over that, like that, they even really a little later too, like that 4, 5, 6 month mark after surgery, that motion kind of slowly get back as things settle down and everything. And you're nervous that whole time because you don't want them to be too tight. But you definitely kind of see that over time. Len, when do you, I appreciate what you just said at 6 weeks, 8 weeks. When do you start to worry more, or when do you start to panic? Is there like a specific zone, like a week or something? When do you start actually feeling like, okay, that little snugness that I liked at 6 to 8 weeks is now behind? When does that happen in this type of person?
Probably I start to think about things around 12 weeks. If like normally in a person who has a shoulder surgery, it depends again on their goals and their age and so many different things and what the surgery was, but around 8 weeks, I like to see close to full motion, or at least beginning to see like the end feel is good and they're beginning to stretch out. We're still making gains in our motion. If it gets to 12, 14, maybe even 16 weeks, if they're really loosey-goosey, then I'll begin. But very rarely do I see a truly hypermobile person who is stiff it's at 14, 16 weeks and I'm freaking out. I just don't see it in my hands because I think they never really get stiff enough that their motion doesn't come back, again, because of their underlying hypermobility that they have. I'm not seeing it. So maybe this person is too early in the time frame to start thinking about, that they're truly stiff. I kind of think they probably want them to be stiff. And I'm imagining the surgeon stiffen them up through a capsular shift or application or something like that. So I'd probably want to see the op report too and see and what they did exactly in the surgery. Because a lot of times the script just says status post label repair or something like that, or Bankart repair. And you don't really know, oh, wait, they did do application in it, but it was never put on the script for some reason. So I'd be cautious to, again, maybe stretch them out too quickly. Maybe we want that stability.
Yeah, communication with the physician, I think, key
Yeah.
with these types of people too. I mean, like you said, you might read the op note and be like, "Oh, there's 9 anchors." Like, well, yeah,
Right.
right.
Exactly.
Like,
Yeah, right.
they're definitely going to be a little stiff there. I think you're generally right. I think you're right. The majority of time is the way you think of it, but we always get that one person stuck in our head, and I think this is what's happening with Hannah too. You get
Right.
that one person that's stuck in your head that has that, and we've all had the person like everything looks good, this motion looks good, this motion looks good, and then just like something hits a wall, and you're like, in your head you're like, is that the anchor? Right? Like it's so specific, like
Right.
one area loss of motion, you're like, there's no way that could be potentially loss of motion. So I think that would be the only thing I would add on to that, to Lenny and everybody's answer. I mean, I think that was like a good overall thought process. If you do have a person where they do seem like they're loosening up as expected, like Lenny said, and you have that nice snugness in there, I think that's great. If somebody has just like that one little specific area that's snug, that's something that you can maybe focus on a little bit, right? Especially as you start getting 12 weeks, 16 weeks. We know at that point the surgery's like healed, right? It's structurally sound and able to be stressed a little bit. You might want to work specifically on that range. Now, if you feel it's a surgical restriction, to me, that's where we're less aggressive. And again, it goes back to more frequency and just low load stuff, is we have to get that tissue to kind of heal a little bit around that new surgical repair. But I would just say that would be the only thing I would add there, Len. Like, that's what I think of, right? And maybe that's what Hannah's thinking. But I think you're right, though. I think probably the majority of the time it goes the way Lenny just said. But we get nervous about that one person where it's like you almost feel like they're hanging on to one tight anchor and you have to kind of push a little bit. So, keep that in mind too, Hannah. I think that's a big part of it, is like Lenny said, 6 weeks, 8 weeks, maybe it's, maybe we're okay with a little snugness. As long as you're seeing progression. And this is where, like, I want you in your head to kind of calculate, like, what's their range of motion? What's the quantity and the quality, right? So how much motion do they have? What's the end feel, right? How does it feel in your hands? And as long as that's like slowly progressing week to week, right, as you're doing your treatments with that person, I think we're happy. I think that's a big part of it that is good for us. If you get one area that seems to be a little stuck, you may have to work on that a little bit. But in general, I think this is going to be one of those things that patience just helps with over time as well. So awesome. So good question, Hannah. I bet a lot of people deal with that too, right? Especially, varied surgeons all over the world. If you work in a clinic where, you get a variety of different surgeons that are sending you people, right? You probably get some people that feel tight, some people that feel loose, and everywhere around that spectrum. So it gets pretty challenging to figure out even that. That's another variable we haven't even talked about is surgical technique, right? So something to keep in mind here too. That's challenging. So great question, Hannah. We really appreciate it. Please head to Apple Podcasts, Spotify, and subscribe, rate, review this podcast. We'll keep pumping them out, and we'll see you in the next episode. Thank you so much.